Welcome to part 2 of gestational diabetes mellitus. So here we will be learning how do we manage a case of gestational diabetes. So in the first part of the GDM chapter, we have studied how to diagnose diabetes, how to screen for GDM, and what are the different criterias, and how HbA1c was affecting pregnancy, and how organogenesis was affected, and what are the congenital malformations which was taking place. In the second part of this, we will come to the management of gestational diabetes. So management of gestational diabetes can again be divided into maternal management and fetal management. Okay, fetal management. And that too, maternal management can be divided into antenatal management, that is antepartum management, that is pregnancy के दौरान क्या management करेंगे, and intrapartum management. Intrapartum management मतलब delivery कैसे कराएंगे. Intrapartum is delivery. Always remember, if in exam you are asked what is the antenatal management, you always tell कि एंटीनेटली क्या करेंगे, एंड इंट्रापार्टम मैनेजमेंट मीन्स डिलीवरी कैसे कराएंगे. सो कमिंग टू एंटीपार्टम मैनेजमेंट. एंटीपार्टम मैनेजमेंट पहले ऑलवेज वी स्टार्ट फ्रॉम हिस्ट्री, एग्जामिनेशन, इन्वेस्टिगेशन एंड देन ट्रीटमेंट. सो हिस्ट्री में क्या क्या पूछोगे. हिस्ट्री में यू हैव टू आस्क द हिस्ट्रीज ऑफ पॉलीयूरिया, पॉलीडिप्सिया एंड पॉलीफेजिया. दीज आर द classical symptoms and signs which you ask, which tells you about the severity of the disease, polyphagia. Okay, so this tells you about the severity of gestational diabetes mellitus is known in this history. Then again you always ask for discharge per vaginum, discharge per vaginum, discharge PV, because discharge PV में candidiasis is very common in women who are diabetic. Then also you ask for any skin infections. Skin infections, these are very important when you take case of gestational diabetes mellitus. You have to take these histories. So skin infection is asked because repeated skin infection and scabs are present because of the high diabetogenic state. Then patients will also have nausea and vomiting because of diabetes. This is because there is gastropathy. Gastropathy occurs in these patients. Then you also ask about headache, blurring of vision, epigastric pain. So these all are imminent signs of eclampsia. Okay, so because preeclampsia is very common in women who are diabetic, because women long term diabetes or pre-gestational diabetes will lead to atherosclerosis, and atherosclerosis is a cause of again preeclampsia. Also you ask about previous history of stillbirth, and all these things are also asked to the patient. Previous history of stillbirth, previous history of any bad obstetric history, any neonatal death, any shoulder dystocia, or any macrosomic baby, difficult deliveries. These are the things which are asked in history. Then coming to examination. In examination of a diabetic patient, you always try to look for the estimated fetal weight. So per abdomen, by per abdomen you try to estimate the fetal weight, and also look for the liquor. If the liquor is very much increased, if it is polyhydramnios, or the baby is very large than the period of gestation, that is macrosomic, then you have more chances of, apart from ruling out multifetal pregnancy, if it is not a twin pregnancy, then chances of macrosomia is high. So these are the examinations that you do. Coming to investigations. What investigations do you do in patients who are coming with diabetes? So you have to investigate the patient for any end organ damage. So first we start with CBC. A routine CBC is done because patients in our country, women are tend to be anemic. So you have to see the hemoglobin. Then you also see HbA1c of the patients. If HbA1c is less than 6.5%, it is well controlled, then chances of macrosomia and polyhydramnios are lesser in later gestation. Whereas if HbA1c is controlled in first trimester, then the chances of congenital malformations is also low. Apart from that, you get liver function test and renal function test done in pregnancy. This is because kidney function and test it can be deranged. Creatinine can be raised if a patient is chronically diabetic, that is pre-gestational diabetes. However, gestational diabetes will not hamper the LFT and RFT, whereas preeclampsia or severe preeclampsia was deranging the LFT and RFT. This is very much important. Then you do a fundus examination or fundoscopy is done, so that we rule out diabetic retinopathy. So in the hypertension class which we were talking today, there we were talking about hypertensive retinopathy. Now we will be talking about diabetic retinopathy. So you all have studied this in your ophthalmology classes. I will be revising once again. Diabetic retinopathy can be of two types. One is non-proliferative diabetic retinopathy. The second is proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy is when there is no neovascularization. जब नहीं है तब उसको बोलते हैं non-proliferative diabetic retinopathy. Whereas जब neovascularization हो जाता है, that is new blood vessels formation हो जाता है fundus में, then you say it is diabetic retinopathy. These new blood vessels which are formed in the fundus, they are very fragile, and so they can rupture any of the time, and if they rupture, then chances of retinal hemorrhage increases. So if a patient of diabetes, long-term diabetes, of course pre-gestational diabetes, develops proliferative diabetic retinopathy, then again it is an indication for elective cesarean section or instrumental vaginal delivery with forceps to cut short the second stage of labor. क्योंकि वाल्सल्वा करेगी तो ये न्यू ब्लड वेसल्स फट जाएंगे. तो जस्ट लाइक आवर हाइपरटेंसिव रेटिनोपैथी, वेयर स्टेज 3 एंड स्टेज 4 हाइपरटेंसिव रेटिनोपैथी, कॉपर वायरिंग एंड सिल्वर वायरिंग, सॉफ्ट exudates and hard exudates, where an indication for elective cesarean or instrumental vaginal delivery. Similarly, in proliferative diabetic retinopathy, when there is neovascularization, then you never give patient very long trial of labor, or second stage has to be cut off or go for elective cesarean section. Very important. So fundoscopy has to be done for everybody. Next is, if you diagnose proliferative diabetic retinopathy in pregnancy and patient is very much willing for normal vaginal delivery, then you can go for laser photocoagulation can be done. Laser photocoagulation can be done of all these blood vessels, and it is preferably done at 18 to 29 weeks. Between 18 to 29 weeks we generally do the laser photocoagulation. But अगर ये 29 weeks से ऊपर हो गया है, थर्ड ट्राइमेस्टर में एंटर कर गई है, then we generally avoid laser photocoagulation and we go for direct elective cesarean section for the patients. Next, you also check for proteinuria in these patients with urine dipstick. If proteinuria is increased, then patients may develop preeclampsia also. Then you also do urine routine. Urine routine is seen for casts. Casts, if it is present in urine routine, then it is suggestive of nephropathies also. So these are the tests which is done. Apart from that, there are fetal tests also done. Fetal monitoring is also done. For fetal monitoring, you get an ultrasound done, whereby you estimate the estimated fetal weight. बच्चे को मैक्रोजोमिया हो रहा है कि नहीं, बच्चा weight more than 4 kg है कि नहीं. If weight is more than 4 kg, we have to go for elective cesarean section. Always, and also try to look at the Liker. If it is polyhydramnios, how do you know when it is polyhydramnios? Polyhydramnios के लिए I have told in the twin pregnancy class, if the AFI, that is amniotic fluid index, is more than 25 centimeters, or single deepest pocket SDP is more than 8 centimeters, then you say it is polyhydramnios. So polyhydramnios, if it is there, then chances of PPROM, that is rupture of membranes, will also be there. So be careful about that. Also for fetus, we get fetal echocardiography done. Fetal echocardiography. Now what is the indication of fetal echocardiography? Why do we get it done? Because congenital heart disease or CVS disorders, I have already told, is very common in infants of diabetic mothers. So you have to detect whether there is cardiovascular disorders in the form of ventricular septal defect, transposition of great vessels, hypoplastic left ventricular, HOCM. These all are found in fetal echocardiography. Okay, so women of diabetic mothers who all are diabetic, for them you have to start folic acid in very high doses. Folic acid has to be started in the first trimester itself. If women is pre-diabetic or over diabetes, then start 4 milligrams of folic acid prophylactically to prevent neural tube defect. Neural tube defect prevention के लिए we start high dose, 10 times high dose. Normal folic acid dose in pregnancy is 400 micrograms. 400 micrograms in pregnancy. Here we are giving 4 milligrams, which is actually 4000 micrograms. 4 milligrams is actually 4000 micrograms. So it is 10 times the normal dose we give in diabetic patients, because diabetic infants are more prone to develop neural tube defect. So always remember, they have to be given very high dose, 10 times higher dose of folic acid. Better to start it 3 months prior to pregnancy. 3 months prior to pregnancy. This has also been a question which has been asked in examination. When is the best time to start folic acid? 3 months prior to planning for pregnancy. So preconceptional counseling mein you have to start. Apart from that, when a patient is diagnosed with gestational diabetes mellitus, the first management which we will start is MNT. MNT is medico-nutritional therapy. Medico-nutritional therapy. Medico-nutritional therapy consists of two parts. One is diabetic diet. One is diabetic diet that you have to very much explain to the patient कि diabetic diet में क्या क्या लेना है. And number two, you have to explain to the patient what exercises she should be doing for weight reduction and insulin resistance कम करने के लिए क्या exercises करेंगे. Regarding exercises, you should remember it should be moderate level of aerobic exercises. Moderate level of aerobic exercises of 30 minutes per day. 30 minutes in a day. Every day she should be doing moderate aerobic exercise. Moderate मतलब माइल्ड एक्सरसाइज नहीं करना है, सिर्फ वॉकिंग नहीं करना है, ब्रिस्क वॉकिंग कर सकती है, साइकिलिंग कर सकती है, योगा कर सकती है. एंड दे शुड बी एरोबिक एक्सरसाइजेस. एरोबिक एक्सरसाइजेस मतलब फ्रेश एयर में एक्सरसाइजेस करेंगे. एंड इट शुड बी 30 मिनट्स इन अ डे फॉर 5 days a week. 5 days a week. So in a week 5 days she should be working. It means the total amount is 150 minutes per week. 150 minutes per week हो गया exercises she should be doing. Okay, this much is required. And what do you mean by moderate level of exercise? This means when you do the exercise, the heart rate should increase up to 120% of normal. 120% of normal means अगर baseline heart rate 100 है तो ये 120 होना चाहिए. If the baseline heart rate is 50, then it should increase to 60. Okay, so 120% of normal. This means it is moderate exercise. Coming to diet, what do you mean by diabetic diet? Diabetic diet means the diet composition should be such that 45% of the meal should be carbohydrate. 45% of the meal should be carbohydrate. 30% of the meal should be proteins. Whatever food is taking, 30% of it should be proteins, and 25% should be fat. This should be the composition. Accordingly you have to tell. Now it is very difficult to say कि carbohydrate, protein and fat कैसे divide करेंगे. So we have a plate method. Okay, so plate method is explained to patients in the OPD. In the plate meal method, what is said is इंडिया का जो फ्लैग का कलर है सैफरन, वाइट एंड ग्रीन. सो दिस 3 पार्ट में हम डिवाइड करेंगे प्लेट को. So when the plate is divided into saffron, white and green, half of the plate should be green, half of the plate should be consisting of green food, the rest of it will be consisting of saffron and white. Okay, so saffron and white should be present in the rest of it. Okay, so how do you actually divide in plate meal method? In plate meal method, you should remember that when we divide the plate into three parts, it should be such that 50% of your plate should be consisting of green food, that is green leafy vegetables should be present in 50% of the food. The rest of this should be green, it should be green. The rest of it will be like 25% will be saffron, 25% will be saffron. This means all the dal and pulses and everything should be there, and the rest 25% should be white consists of your rice and chapati. Rice and chapati should be 25% of the plate. So this you will explain to the patient. Apart from that, the carbohydrate that the patient is taking should be complex carbohydrate. Complex carbohydrate consists of all the foods which have a lot of roughage, like the food which will have fibers in it. So these fibers will decrease the glucose intake, so they will have low glycemic index. You have to mention all these things when MNT is asked in examination. Low glycemic index, complex carbohydrates are taken. Out of which, when you divide the carbohydrates, remember in breakfast, lunch and dinner, when you are having the carbohydrates, remember minimum carbohydrate is taken in the morning. That is only 10 to 20% of the carbohydrate is taken in the morning. 20 to 30% of the carbohydrate is taken in lunch, and 30 to 40% of the carbohydrates, that is maximum carbohydrate, is taken in the dinner. So there will be three major meals and there will be three small snacks in between. So you should have small meals at frequent intervals. So three snacks in between. So all these three snacks will be containing 10% of carbohydrates each. 10% of all the carbohydrates will be contained in each. So three small snacks लेंगे and three major meals लेंगे. उसमें से morning में सबसे कम carbohydrate लेंगे and night में सबसे ज़्यादा carbohydrate लेंगे. The reason is in the morning the cortisol level is highest in the blood, and cortisol level is diabetogenic because it is anti-insulinogenic. तो already cortisol, insulin resistance high होता है in the morning. So breakfast will consist of least carbohydrates and night में you will have more carbohydrates, so that overnight, midnight hypoglycemia is prevented. Somagai effect is prevented. So how do you calculate the total kilocalories? कितना total kilocalories लेना है? That you will calculate depending upon the BMI of the patient, basal metabolic index of the patient. Normal BMI is 18.5 to 24.9, okay, kg per meter square. So if the BMI is normal of the patient, then you give 30 kilocalories per kg per day. 30 kilocalories per kg per day. So normally if you consider the average weight of an Indian is 60 kg, तो अगर 60 kg है तो 60 into 30 it roughly amounts to 1800 kilocalories. So 1800 kilocalories we generally recommend pregnancy में लेना है. Okay, if the patient is overweight, that is if the BMI is between 25 to 30, 5 बढ़ा दिया, then हमारा अगर overweight है तो हम खाना कम खिलाएंगे, तो it will be 25 kilocalories per kg per day. Okay, 25 kilocalories per kg per day. And if it is high, more than 30 kilocalories per that is kg per meter square, then it decreases to around 15 kilocalories per kg per day, 15 to 20 kilocalories per kg per day. And if the patient is underweight, that is BMI is less than 18.5, then you have to give very high quantity of food to these patients So the kilocalorie amount will be raised and it will be 35 kilocalories per kg per day has to be given to the patient. So remember, अगर weight कम है then ज़्यादा food देंगे, अगर weight ज़्यादा है तो हम कम food देंगे. So this is all about MNT. So giving MNT, what is our goal for the patient? हमारा goal क्या है, कितना कम करना है हमारा sugar? Our fasting goal should be between 70 to 90 milligrams per deciliter. So this is our goal of fasting. Fasting should be below 90 milligrams per deciliter is our goal, which we will be keeping. Then our post meal, postprandial blood sugar should be less than 120 milligrams per deciliter is the goal which we will be keeping. Okay, and HbA1c of less than 6.5%. This is the goal which we are keeping and we should be doing that. But if on MNT, that is exercise and diet, sugars are not controlled, then we will start on either insulin, we can start on insulin therapy, or we can start on metformin. Okay, metformin is a drug which is safe in pregnancy. Metformin कैसे action, what is the action of metformin, what is the action of insulin, these all things you have already studied in medicine, so I am not going into much details. Okay, so insulin dose, how do we calculate in pregnancy? Remember, insulin dose is around 0.7 to 1 international units per kg per day is the starting dose that we start in pregnancy. The best possible insulin that we start nowadays, which is recommended by DIPSI guideline, is insulin mixtard. Insulin mixtard. What is insulin mixtard? Human insulin mixtard is a combination of regular insulin and NPH. Regular insulin and insulin NPH. NPH is neutral protamine hagedon. Regular insulin is a short-acting insulin, and NPH insulin is an intermediate-acting insulin. So we give a combination of short-acting and intermediate-acting insulin in a dose of 30:70, in a dose of 30:70. Okay, so this combination is used and insulin mixtard is given. Insulin mixtard is given 2 times in a day. It is given 2 times in a day. Okay, so BD dose is given 12 hourly, just after meal, just before the meals it is given. Okay, one more criteria which used to be used earlier, nowadays it is not in use, is we can start regular insulin and NPH separately. We can start. How do we separately start? We divide the dose into 2/3 and 1/3. 2/3 and 1/3. 2/3 is given before the breakfast, and night time 1/3 dose is given. Of this, you divide the 2/3 into again 2/3 and 1/3. Morning dose can be again divided into 2/3 and 1/3. 2/3 will be NPH and 1/3 will be regular insulin, and night dose जो 1/3 है that can be divided into half and half. Half is NPH and half is regular insulin. That used to be used earlier, but nowadays since we have a combination which comes in the form of mixtard, so we generally use mixtard. 30:70 combination is used, and it is used 2 times daily. Okay, now coming to how do you deliver the patient. Delivery of the patient is based on obstetric indication. So if patient is placenta previa or breech or all these things, then we go for cesarean section. Otherwise we go for trial of labor and we induce the patient. When do you induce the patient? Remember, if patient is gestational diabetes mellitus and controlled on MNT, diet से control हो गया है, then you induce the patient at 40 weeks period of gestation. 40 weeks पूरा term तक 40 weeks तक जाएंगे. But if patient is GDM patient and she is on oral hypoglycemic agents, that is metformin, or if she is on insulin, any kind of drug is being given for controlling diabetes, then you induce the patient at 38 weeks period of gestation. Otherwise, very high chance of baby becoming macrosomic or sudden infant death. Sudden infant death or IUFD is very common in diabetes. Very very important. Sudden death हो जाता है after 38 weeks. So you go for induction of the pregnancy at 38 weeks. What are the indications of cesarean section? Elective cesarean section. Indications of LSCS in a patient of diabetes. Very very important. Number 1, if the estimated fetal weight is more than 4 kg in Indian scenario, then we go for elective cesarean section. And if it is 4.5 kg in Western countries, then they go for cesarean section. Number 1. Number 2, some of the times you get two options, 4 kg and 4.5 kg. Then preferably give 4.5 kg. Okay, 4.5 kg is prediction of macrosomia. Okay, or if there is fetal compromise, there is fetal distress of the baby in diabetic patients, then तुरंत cesarean करना होता है, otherwise patient will land up into IUFD. Or if the patient is having very bad obstetric history, बार बार patient का बच्चा IUFD हो जा रहा है, then we can go for elective cesarean section in such patients. Or if there is elderly primigravida, okay, she was having IVF pregnancy and conceived after much precious pregnancy, then we can go for cesarean section. Or if there is cephalopelvic disproportion or contracted pelvis. Okay, or if there is placenta previa, placentomegaly because of placentomegaly because of diabetes and landing up into placenta previa, then you have to go for cesarean section. Otherwise we go for normal vaginal delivery. What are the complications of diabetic mothers? What are the complications is the next question which is asked. So complications can be again divided into maternal and fetal. Always divided into maternal and fetal. Maternal complications can be infection. Then pregnancy induced hypertension. There can be concomitant preeclampsia in pregnancy. Then you can have other complications like polyhydramnios. Polyhydramnios can lead to PPROM because rupture of membranes can occur. Then later on in life, patient can develop type 2 diabetes mellitus also. Fetal complications can be in the form of congenital malformations if there is pre-gestational diabetes. Later gestation में अगर sugars बढ़ता है, then baby can develop macrosomia. Then there can be polyhydramnios. There can be intrapartum dysfunction, that is there can be shoulder dystocia. Shoulders अगर बड़े हैं तो डिलीवरी में दिक्कत होता है. There is increased chances of cesarean delivery, LSCS increase हो जाता है. Apart from that, there can be sudden stillbirth and sudden respiratory distress syndrome. So always remember, lung maturity is very late in diabetic patients. So respiratory distress syndrome occurs in diabetic mothers. So if you are planning early termination of pregnancy, that is before 38 weeks, if you are terminating the baby, then always try to look for lung maturity of the baby. So how do you look for lung maturity of the baby? Normally we do lecithin to sphingomyelin ratio, and if it is more than 2:1, then it is suggestive of lung maturity. But in diabetic mothers, lecithin to sphingomyelin ratio is not done. This is not reliable. In diabetes, very important, the reliable marker is phosphatidylglycerol. Phosphatidylglycerol is the marker which is specific for diabetic mothers. So phosphatidylglycerol is confirmatory. for diabetic mothers. This is done. If the lung maturity is not good, then you have to go for corticosteroids, that is dexamethasone cover has to be given before termination, and dexamethasone itself will increase the sugar of the mother, so glucose level will increase, so you have to start the mother on insulin therapy when you go for dexa cover to the mother. So this is how we deliver the mother, and in the intrapartum period always try to look for, if there is cephalopelvic disproportion, you have to go for elective or emergency cesarean section. And if the mother's sugar level rises very much, then you have to start insulin therapy during labor. Insulin therapy has to be started in labor. So this is all is asked to you in diabetes. I hope you have understood. Any doubts, anytime you can call me up or ring me up and ask me. Thank you so much.